minutes of this meeting will be prepared as soon as possible following the meeting and uploaded onto the CPG area of the Rural Policy Centre website. And the minutes will be formally approved, hopefully, at the next meeting. And once you've seen them, if you can send the RPC an email if there's anything that needs to be corrected. So hopefully we don't have a whole list of corrections this evening, but they'll make sure that any points are picked up. So firstly, I'd like to look at the minutes from the last meeting, which took place on the 16th of November and focused on keeping food local. I can confirm the Secretariat have not received any comments or queries on this. So the minutes are on the minutes, that is. So I'm assuming there will be none tonight. You can raise your hand. Now, somebody has raised their hand. So there must be a problem. I can't see your name. I'm sorry, my eyes are too poor to do that, but
Fiona Morrison.
Fiona Morrison, I think you want to say something.
Yes, if I may, convener. Yes, and I'm sorry, we did only receive the minutes quite late in the day, so I wasn't really able to do anything. And indeed, I contributed to an aspect in them. So just 2 points, if I may, convener. One, I think in the notes under Professor David Marshall's presentation, there is a line there which I feel shouldn't be kept for ongoing basis, in that it says that crofting skills are being lost. And I think we need to counter that and say that's not necessarily the case. Since the introduction of a crofting course at the school in Benbecula, the average age group profile of pupils in North and South Uiston, the agricultural committees has in fact dropped by a generation. The access is, the issues are to do with aging demographic of crofters. It's older than that of farmers, and also access to land by younger crofters. But in terms of skills, that is not the case. The SCQF level 5 course is being delivered and has been oversubscribed since 2008 and was in fact launched by the Cabinet Secretary for Environment at that time. And as I say, that the influence of that we've seen in the agricultural committees, and also the Farm Advisory Service and the Scottish Crofting Federation are delivering a course even tonight as we are at this meeting. So I just think that sentence shouldn't sit on its own. Crofting skills themselves are not necessarily being lost. It's the issue of access to crofts and younger crofters, which is the issue, which gets in the way of that becoming more thriving, which I hope it will become. And the second point, if I may, is under the support for local producers, my name is quoted regarding a project running in Greenland that came out of our Northern Periphery research, except it's not spelt correctly. I'm sorry. And if anybody wants to challenge me or ask me about where that work comes from, then I guess my name ought to be spelt correctly. So I'm sorry. So apologies. I wish my name was Anne, but it is in fact Fiona, not Fiona. And if it could be corrected, that would be fine if anybody wants to follow up on that. And my apologies for being the first troublemaker this evening.
You're not a troublemaker. I always hate it when people spell my name wrong. Usually confuse me with Manson, which annoys me because he was a mass murderer. So we'll get your name right. I'm really sorry about that, and I accept fully that skills aren't being lost from crofting. It's the ability to get to crofting, which is something that we need to tackle. So we'll address that. Is there another hand?
So David.
Oh, there's another. This one, is this a troublemaker? Let's see. Who's this?
Hi, David Marshall here. Thanks, Fiona, for that. I think it'd be very useful to qualify that. However, we are simply reporting on some of the feedback that we got when we spoke to people. So, but I'm happy for that to be qualified.
Thank you.
Thank you.
Now, please take your hands down in case, unless you want to come back in. Ah, perfect. Oh, we can move on. Great. Look, I'm sorry for those mistakes. We'll correct those and we'll get them right. And subject to those being corrected, are we happy to approve the minutes? Somebody who was there, can you approve them? Stick your hand up if you're there and you can approve them. Oh, there must be somebody. Have we got a list of people that
David Marshall can.
David Marshall, you're happy to approve it? And anyone else? Yep, I see another hand come up. Who's that?
Fiona. Thank you, Fiona.
Thank you very much. I knew you weren't troublemakers. You were being really helpful, and thank you for approving the minutes. So moving straight on then, we've got 5 presentations tonight. And this is news to me. I wasn't going to be here this evening, but we've got a couple of double acts. Our first 2 speakers will focus on providing contextual information about mental health in Scotland, in rural Scotland, and health in rural Canada. Then our 3 subsequent presentations each focus on a different kind of health and wellbeing initiative in rural communities in Scotland, Ireland, and Sweden. Now, I'm told each speaker has a maximum of 8 minutes. Anyone who's watched my committee know that I usually wiggle my pen when I'm getting close to the 8 minutes, and when it goes off the scale, it's usually coming in the direction of the speaker to tell them to end. Doesn't always work, of course, when we're hybrid, so I won't cut you off, but you'll get the message if we get there. And you'll have to interpret what Emma does when she arrives. So we know that COVID-19 pandemic has had very serious implications for many rural residents and communities, as movement and social mixing was restricted, leading to challenges with isolation and mental health for many people. Now, we're going to cover some of these issues through our first and second presentations, but then, as I mentioned at the start, we'd like the meeting to focus on different positive solutions to these challenges, and each of our presenters will provide insights from their own experience in Scotland, Ireland, and Sweden, hoping that we can learn across the national context and see some common threads arising. So we'll run through the presentations, if we may, just one straight after the other, and then take questions and comments after all of our speakers. Now, Jim Hume, I think, was supposed to be here, but he's unwell. So is it Kira McDermott, Senior Policy and Public Affairs Officer at Change Mental Health, discussing mental health in rural Scotland? So that's you.
That is me.
Good. It's always good to know where your speakers are sitting before and where you'll find them as a convener. And you're fired but reinstated. Off you go.
Thank you very much, convener. Yes, so Jim is sadly unable to be here today, so you have me. I am by no means do not have his expertise, to be honest, but I will do my best to live up to him. If I could have the first slide, please. Yes, so as I said, so I'm from the national mental health charity Change Mental Health. So I just want to start by saying quickly that every single person in this room experiences mental health, whether that be positive or negative, and it is everybody's business. If I can have the next slide, please. Sorry. So I'm going to give you a very quick, as quick as possible, wee chat about what is going on in Scotland, rural Scotland, on mental health. So to begin with, where did this all begin? So the National Rural Mental Health Forum, which is run by Change Mental Health and SRUC, basically realised there was a massive gap in terms of mental health research. A lot of it focused on urban areas in Scotland, and there's basically not much data, to be honest, on rural Scotland. So that's where we partnered with SRUC and did the National Rural Mental Health Survey in 2017. Oh. There we go. Sorry. Okay, so I'll just give you a few examples of the findings and key points that came out of this. So a massive one is public transport. So often it's cited that a lot of people living in remote and rural Scotland are unable to actually access mental health services and support due to the lack of transport, or the fact it's maybe a bit sporadic and isn't always showing up, so they can actually get to the service, but then the bus is in 3 hours, or it's not actually till the next day. So that's really interfering in them actually getting the proper care and treatment that we need. A second key thing is the lack of anonymity. So people are living their lives very visibly with their neighbours, their community, and quite often the people that are actually providing those mental health services and support are their neighbours, their friends, people they know, and due to the stigma related, possibly their job, they don't want to go and actually seek that support. And finally, the key point here is that there's actually just a lack of local services. There's a lot of the time these services are concentrated in more urban areas or where they have that high population number where services can actually be justified for ongoing provision, which again, not great if you needing that support. So now looking at COVID, I just want to say that those points that came from the National Rural Mental Health Survey are still existing now. They've not gone away. They're continually coming up in many of the National Rural Mental Health forums that we are running. But from our own research with COVID and different research that's coming up, there's kind of 3 additional factors that are really affecting people. So first one is digital exclusion. So we know that during the pandemic, a lot of mental health services and support did in fact go online, which obviously great. People still needed to access that support. But for reasons, a lot of people in remote and rural in Scotland were unable to access. So due to their broadband being too slow to do video calls, to not being able to afford fast enough broadband, or actually a lot of people with poor mental health don't trust digital means, and they find it a source that they're not quite sure what they're going to get from it. The second is actually social isolation, which I think a lot of people in this room probably experience themselves. But a positive thing that tends to come out from a lot of the research on mental health in rural Scotland is that people enjoy being in their community. They have that aspect of going to local community halls and engaging with community groups, and suddenly being cut off from that was really detrimental to their mental health, and there was no face-to-face interaction, and all of a sudden these people who were maybe really social in the community are now actually struggling to get back out there. And then the third one is actually the financial implications. So one that came up with literally last week at our latest forum was the fact that their businesses were being affected. So say there was an example somebody gave of usually they would sell their produce at a local market and they were unable to do so. And again, that's really negatively impacting their mental health. So another key thing that is coming out of this is, along with COVID, obviously, we now have this cost of living crisis, which, as you can imagine, we have a lot of research that shows that there are clear financial concerns are clearly linked with poor mental health. So, for example, people who are experiencing poor mental health due to the anxiety of being unable to pay their bills, maybe getting into debt, they're currently having to choose between feeding or heating their house. And we know from research that's a lot more prominent actually in rural Scotland, where energy prices are higher, houses are maybe less energy efficient, and your food shop can be a wee bit more expensive as well. So how are we basically helping with this? So we have at Change Mental Health a mental health and money advice service. So this has actually been going since 2017. So the service essentially provides support, advice, advocacy and representation for people who either have poor mental health, I'm talking severe enduring mental illness, or they have money worries. So we're very unique in comparison to other money advice or debt agencies. But what we found really interesting is a few months ago, one of our advisors pulled together some data and told us that about 40% of clients are actually residing in rural Scotland, with many of them currently seeking that support for the cost of living crisis. And these are people who've maybe necessarily never claimed benefits before, but they're really needing that help now. And we've not looked at the statistics again, but I'm going to the next few weeks and we're assuming now that that's actually going to be a lot higher, as you can probably imagine. So I suppose that's been a very quick kind of whistle blow of all the facts on mental health in rural Scotland right now. So what are we actually doing to help this? So through the work of the National Rural Mental Health Forum, we are regularly engaging with the Scottish Government actually at the forum seminars. So recently, actually last week, we just had the suicide prevention team in, and previous before that, we held some seminars and breakout rooms on the new mental health and wellbeing consultation document. And with that, we basically have been responding to different consultations through getting responses from the members of the forum. We then also have had a very high presence at some of Scotland's agricultural shows. So, for example, the Highland Show, the Black Isles Show, and we've had lots of really great feedback from that. We've had people actually coming up to us and opening up about personal stories about mental health in their areas. And it's a good way to kind of reduce that stigma and also to raise awareness of mental health. And then the final thing, we also have our Rural Community Engagement Project that has been funded by the Scottish Government. So we've actually been giving out micro grants to local communities in rural Scotland. And basically, this money, it can go towards any form of activity or local group or organisation, and it's to help promote good mental health whilst recovering from the pandemic. So I've actually just got all the reports in for that, some today, and I'm getting the rest tomorrow, so it'll be interesting to see the kind of benefit that that has had. And then finally, another key thing that we're doing is we know that mental health training really works. So we actually provide the Rural Connections project, which is funded by Neptune Energy. And essentially the project's aiming to really promote good mental health and well-being throughout rural Scotland. So it provides fully funded online mental health training. And for all our research we've done, that we know that mental health training really helps to build resilience in your community. So this can be for rural businesses, but also just organisations or your local community. And it'll allow people to be first responders, notice if anything's going on with somebody, know how to signpost to local services and support. So we know from our research that about 82% of people after completing this training felt way more comfortable and actually had those skills to be able to talk to people about mental health, which in turn is hopefully going to reduce any moments of distress and really help people pre-crisis. And I'm just going to end there with some sources of support, which I know this might be of use, where basically we've rebranded now. So there's a few services that we offer ourselves, but also some of the key ones like Breathing Space and Samaritan. So if anyone's needing any additional information, I'm happy to chat at the end. Thank you.
Thank you, Ciara. Hi, everybody. I'm so sorry I'm late. The chamber just finished, and Edward, thank you for starting the meeting. I know technically we're not supposed to start until chamber's done, but sometimes it just means that it inconveniences everybody and then pushes us back to be so late. So thank you for starting the meeting. I owe you half a one.
I'm not sure what half of what, but it's not half a meeting. It's going to be half a session in the bar later.
So thank you. Thanks, Ciara, again. I will just continue, and our next speaker is Associate Professor Leith Deacon, all the way from the University of Guelph. Is that right? Who will discuss the outcomes of his rural responses to COVID-19 survey, highlighting the findings on reported differences in individual wellbeing in rural Ontario before and after the pandemic. So welcome to you. I will hand over.
Thanks so much. I'd like to start by thanking Jane Adderton for inviting me to be here today and to give a perspective on the experiences of Canadians within rural communities around mental health and COVID-19. I also would like to contribute to the conversation around name as a Canadian whose first name is Leith. It's super wonderful to get a coffee from Starbucks and not have to spell that out to the barista. So that's sort of off topic. So I know that I'm on a strict timeline. 7 to 9 minutes is super difficult given what we are here to discuss, but I want to provide a quick overview of Canada because it does provide some important context. Everybody understands that Canada is a super large country. We have a population of approximately 38.25 million, which is slightly less than the state of California, but about 10 million more than Australia. Rural or rurality is far from a universally accepted definition, but what is understood is that there are about 8 million Canadians that live in small and rural communities. 8 million, if you're wondering, that is slightly more than Hong Kong, slightly less than Switzerland. In Ontario, which is Canada's second largest province by area, largest by population, there are between 1.5 and 2.8 million Canadians who live in small and rural communities. Canada achieved the highest rate of vaccination amongst any of the G8 countries and one of the highest in the world. Approximately 94% of us received at least one dose, and somewhere in the neighborhood of 85% of us are fully vaccinated. That being said, there were over 4.5 million cases of COVID positive across the country, and Tragically, over 50,000 Canadians lost their lives. I do want to make a special note, 4.5 million is sort of a problematic term. Canada, like many other countries, simply stopped tracking. I can speak from my own house. Everybody tested positive twice. So that gives you a little bit of an idea. Despite the 8 million count, rural residents in Canada continue to be systemically neglected by all levels of government. Rural residents have been found to have higher levels of substance abuse, domestic violence, depression, and child abuse. Additionally, residents across rural and remote communities have higher rates of suicide than their urban counterparts. In fact, suicide is the leading cause of death for males under the age of 50 within Canada. Concurrently, increased stigmatization for receiving psychological support increases in rural locations compared to urban communities. And additionally, comorbidities, including low rates of self-reported health, lower rates of physical activity, higher rates of obesity and smoking all exist. Quite simply, mortality from preventable causes increases with remoteness or rurality in Canada. There is a need for all levels of government to recognize that rural experiences are different than that of urban, and this does remain a challenge across country, especially when politicians, no offense made, are often focusing in terms of term limits or vote count. The reality is that rural residents cannot sway a vote in Canada, but here's what they do. Rural communities are the breadbasket of resource extraction, not only in Canada, but across the globe. Canada is unique in that it is a highly developed country. However, it is a net exporter of resources, including oil, gas, and critically food. 1 in 9 Canadians work in the agriculture or agri-food sector, and the natural resource sector, excluding agriculture, contributed $380 billion to the Canadian nominal GDP in the second quarter of 2022. That being said, the focus of policy and research remains urbanly focused. So what I wanted to do was develop a project that didn't do that. I wanted to explore the experiences of residents from small and rural communities related to the ongoing COVID-19. I developed and distributed a survey, which was fully quantitative, across 9 rural-based counties in Ontario. There were 5 sections of the survey. Today, I'm here just to talk about mental health, but within each one of those sections, participants were asked to reflect on life before the start of the pandemic so that we could have a baseline of where to start our evaluation and analysis, and then to reflect on things, how they've changed since the start of the pandemic. In total, we ended with just shy of 23,000 completed surveys, which is now the nation's largest database of rural-focused information. And let's just kind of jump into some basic information. So what you're looking at right now is an aggregate total of mental health disparities that have took place since the start of the pandemic. What you're looking at is a net decrease of 50% in self-assessment around mental health in that excellent category since the start of the pandemic. Flipping to the bottom part of that chart, which is the most alarming concern here, nearly an 85% increase in participants who said since the start of the pandemic, they now reflect or assess their own mental health as poor. Quite honestly, that should be enough to stop the presentation because those numbers are so alarming. Moving on a little bit, however, we also wanted to focus on gender because, like it or not, simply being a female or self-identifying as such is an indicator of vulnerability. Females are disproportionately impacted by virtually everything. They are more often precariously employed, they are paid less than their male counterparts, and they continue to do more at home. Unfortunately, our information and our data collected only corroborate those findings and that females were disproportionately impacted compared to their male counterparts on all indicators. I'm not here to say that males should be neglected or ignored in any way, but rather we need to ensure that when we are developing response plans, we do so in targeted fashions. What works for a 50-year-old self-identifying female simply will not work for a 50-year-old self-identifying male. It's important that those considerations are taken into account. We also wanted to look at the impact of age because the overwhelming message that came out of all levels of government during the start of the pandemic and getting into the first year was stay home to keep your grandparents safe. It was pretty straightforward. Physiologically, that might make sense, but all of our data does not reflect that. In fact, all of our data indicates that individuals under the age of 50, more so under 40, and critically individuals under the age of 30 across all genders have been disproportionately impacted from a mental health standpoint. The reality is, again, we need to ensure that our responses, our policies, our emergency management reflects the realities that people face. A 70-year-old's experience is not discounted or neglected, nor should it be, but to assume what works for that individual will work for a 30-year-old is being naive. And it's critical that we give considerations to all demographics. Now, I was the timelines were pretty strict here, so I'm just going to wrap up with some recommendations. I obviously could go on for a lot longer. I have nearly 25,000 responses, but here are my top 5 recommendations. And I know that this is Canadian-based information, but I think it is useful here. The first is an education campaign. There simply is a disconnect. What is the difference between mental illness and mental health? They are not the same thing. Someone that suffers from bipolar does not have a mental health issue. That is a mental illness concern and requires specified medical specific information and response. The public doesn't typically understand that. We also need to ensure that our responses are targeted. And again, I've already said this, but we need to ensure that if we're developing response plans, emergency supports, they make sense for the people who need it. Again, if you want to ensure that all individuals from a population get the support they need, don't one size fits all blanket it. It's really important that time is taken to understand that population. And in my opinion, the only way to do that is to gather information from that population. And the next 2 are all about funding. As the conversation started with, rural areas have been chronically underfunded no matter what country you're in. We lack social supports, we lack social funding for service provision. In Canada, we are a referral-based healthcare system. All that means is in order to access any sort of specialized care, we need a GP referral. We are chronically lacking GPs in rural areas, and therefore it is very difficult to access those services rather. Telemed is excellent, virtual care is awesome, but we lack accessible, reliable broadband to do that. And it's very difficult to come up with solutions when we assume that service provision has been equitable. And last and most important, I would argue, we need to ensure that rural proofing occurs on all policies. I understand that sitting here in Edinburgh, this is your parliament, and this is where all of your policy decisions are made, much like London, much like Washington, much like Ottawa. I understand that. But again, if in fact we are going to develop equitable, responsible, reflective policies, rural has to be given adequate consideration, adequate time, so that whatever it is that we're designing, whatever it is that we're developing is reflective of the realities of the people that need that help. Lastly, I want to thank everybody again for welcoming me here today. Rather than say questions, I am super aggressively pursuing collaborative opportunities outside of Canada. Obviously, Scotland's different, but we have a whole lot more in common than we do different, and we have lots of opportunities to learn from that. So all of my contact information is there. And I would welcome any sort of contact. Thanks very much.
Thank you, Leith. Rather than take questions, I should have said at the beginning after Kira, we'll just take questions at the end if that's okay with everybody. So I'm going to introduce our next speaker ×2. Ailsa Clark from Inspire Alba and Lilia Latigo Sinclair from Positive Action /Heal Scotland, and you're going to discuss the health and wellbeing challenges and responses from a rural community-led perspective. I hope that is correct.
There we go.
There you go.
Thank you, and thank you for the introduction. That is a very hard presentation to follow. A lot of, really important statistics gathered there, and I think we would find very similar traits in our own rural areas. So thank you for that. So I'm just going to start. My name is Ailsa Clark from Inspire Alba, and I run a social enterprise based in Campbelltown in Argyll, and we provide support to a range of social enterprises. So I'm going to talk about that perspective from a community-led perspective, and then I'll pass on to Lilia to talk a bit about the work that she's doing in more detail. So if you want to just, do you want to try that? Okay. See if you can, if not, I can do it for you. That's great, thank you. So first of all, I think it's really important to note the wellbeing challenges as a result of the COVID lockdowns and the isolation that people faced. I think in rural communities we're used to being isolated, but the kind of personal and individual isolation that we faced due to everybody, having to be in their own space, I think has caused additional issues, and that's certainly what we're finding in the work that we're doing. increased needs in terms of responding to those challenges, and you know, we found that rural communities did respond really effectively. Social enterprises and community organisations stepped in and stepped up very quickly to the additional needs during the pandemic. However, that also meant that there was an awful lot of additional pressure and people working to constantly challenging and constantly changing parameters, but doing so very effectively and using their connections in their communities. But that prolonged period of stress for those frontline organisations has an impact as well. I think particularly given that we've come out of one crisis into another crisis in terms of cost of living and huge issues for rural communities, in particular in relation to fuel poverty. So it's not really been we're dealing with a crisis, now we have time to recover. It's been we're dealing with a crisis and now we have another crisis which has an impact. But from an assets-based approach, I think it's really important to recognise the huge assets that we have in our rural communities, those close-knit communities that were able to come together very quickly, know the connections, make things work, and have continued to do that. People know people and they work together. And actually, I think one of the positive outcomes has been that whereas perhaps historically groups would do their own wee bit in their own space, there's much more interconnection and collaboration, I think, to maintain those positive benefits that were created. You know, and we do in our rural communities have a much higher precedence of community-led enterprise and community-led response. 33% of Scotland's social enterprises are in our rural communities, with only 17% of the population. And the more rural and remote you get, the higher that percentage is. And we also have an abundance of natural capital. And I think we all recognise the huge benefit that we can gain for our well-being from that natural environment that we are often surrounded in. So just to give you a snapshot from some of the work that we're involved in, and like many social enterprises, we were able to pivot and evolve our services based on need. So we've always done an element of employability and support work for unemployed individuals in our communities. And it became very apparent that our young people were very much adversely affected, or a number of our young people were adversely affected with increasing issues of anxiety and depression. And young people who would perhaps have been moving into employment were struggling much more because of the additional isolation that they'd faced. So we took on a programme to support individuals pre-employability to get them more ready to move forward. And from some of the initial engagement work that we did, more than 50% of the young people that we worked with had faced mental health issues. And I think that, you know, really chimes with the previous presentation. So again, using those kind of connections that we've established in our communities, we were able to network with a range of other youth organisations and community-based organisations to develop and tailor flexible support, which is very much based on the individual's needs and can be anything from getting a leisure pass with some additional support to get people out and reintegrated, through to one-to-one counselling, as well as things like courses and training and things. And we've seen from that there's been a much higher, there's been a great improvement in terms of people's feeling of mental health and well-being as individuals, but also their ability to move on and progress into other opportunities. So I'm going to move on now to Lilia and pass on to yourself.
Hi, my name's Lilia. Let it go, Sinclair. I put the let it go in the middle myself. And I'm the founder of the Heal Scotland movement and the co-author of the book Scotland's Wild Medicine. I think, like a lot of people here, I've been concerned for quite some time about the picture, our health picture and the health picture of my children and grandchildren. So I decided that a lot of people were suffering, getting sick and staying sick because they didn't have the right information on how to get well and stay well. And a huge part of that is our disconnection from nature and we've been driven inside, fake lighting, fake heating, etc. And inadvertently, we've cut ourselves off from the electromagnetic field that actually interacts with the body and keeps us supercharged and alive and well. That's one of the things anyway. So Ailsa helped me. When I met Ailsa, I didn't know anything about social enterprises, so I decided to set it up as a social enterprise because this is for the people, by the people. I do not believe a politician will fix this for us. I believe that we have to create a groundswell, and part of that is to educate, inspire and support people. So what are we going to do about that? And I have thought about this for a long, long time. And I believe it's got to be through fun. It's very difficult to sell health to people because it just sounds boring. It means I've got to give up all the things that I love, stop eating all the things I love, stop going out at weekends. Now, we're never going to engage the masses like that. So we're having a health and wellbeing festival, wild medicine festival, and we're going to promote the Wim Hof instructors because obviously we're using the super brand who's created Freeze the Fear. People are living in fight or flight and we need to get them out. We need to teach them how to get out. And at the festival, we've got an array of Wim Hof instructors. We're going to make a huge noise and try and get as many people as possible. We want to train breathwork instructors to go to our rural areas and islands so that in the communities, a bit like the AA programme where you have the people helping the people, because I think that model has worked really, really well. So something like that where we're not looking for some guru to fix us, we're looking at the people supporting each other. We've got huge science that tells us community and altruism heals. So when we start looking after each other, looking after our plants, looking after the earth, guess what happens? We get better. So that's where I'm at. Is that our time?
Yeah, no. Just really to draw that together then, I think, you know, one of the benefits that we're able to draw on is that joined up approach, bringing people together, wellbeing focus with a range of activities and support for people, and recognising the plethora of incredible natural environments that we have around us, whether that's going for an early morning dip, which I find helps keep me well, or whether it's, you know, going to a ceilidh, you know, all of these things have a way of making you feel better and bringing people back together for their well-being. And we've been able to link up through Community Wellbeing Exchange Funding. So a lot of the frontline workers that have been struggling in their community-led enterprises can tap into the kind of support measures that we've spoken about with that targeted outreach approach. And with the Wild Medicine Festival, you know, it's about getting information out to the wider public. So again, there's contact details for ourselves, and if anyone wants to follow up with us, we'd be happy to speak to them. So thank you.
Great, thank you both, Lilia and Let It Go. And Ailsa, thanks very much for that. Okay, our next speaker is Professor Liam Glynn from the University of Limerick. So he is going to be speaking to us online here, and he's also a practicing GP and will be discussing practice in healthcare and rural communities in Ireland. So welcome, Dr. Glynn. Thank you for being here.
I'm delighted to be with you this evening and thanks for the invitation. Can I just check you can hear me? That's all, is it? Yeah,
Yes,
great. Some nodding
we can
heads.
hear you.
Okay, that's wonderful. That's always a concern when you're using technology. I'm not 100% sure how I move my slides, but is somebody doing that for me? Oh, great. Yeah, great. And you can go on to the next slide. I mean, I suppose to give you a little bit of background, I work in this area highlighted here in green on the west coast of Ireland. I'm about 25 years a rural GP, and I suppose I'm trying to distill down some of the things I've learned in my my efforts to try and look after these small rural communities in West Clare. We look after about 8,000 people spread over about 600 square kilometres, and this is one of the places I go to when people have been talked about mental health. So this is my mental health place. It's a lovely meadow up on top of one of the mountains overlooking Galway Bay. And these lovely flowers called the spring gentian, they're actually an Arctic flower left behind by the glaciers. They appear every April and May. So I think we all need our spots. But of course, this is one of the really attractive things about being somebody who lives and works in a rural area. And I think this is one of the things that we really need to give a lot of thought to is the narrative that we create around rural. And I've been at a lot of rural meetings. I've heard a lot of people speak about rural, we have to be careful not to create a self-fulfilling prophecy. around the negativity. And it's certainly something that we've really adopted in terms of recruitment and retention for rural general practice. It was already mentioned as a big challenge, I think we really need to highlight why it is so special. We conducted a research study recently, interviewing rural GPs working all over Ireland, and whatever about the challenges, the vast majority of them have been working in their communities for 20, 30, 40 years. So there's a reason that's the case. So next slide, please, if we can. So I suppose the COVID-19 pandemic was a very interesting experience for us all, I think. This is a paper we brought out early in the pandemic here in Ireland because we were involved in the pandemic response. And I suppose what it really highlighted for me, the whole experience, was the response of rural communities that's already been mentioned. And I was really curious because as the different waves of the pandemic came through our country and our community, it was notable in my frontline experience how, in many ways, rural areas escaped the worst of it. And this was a question that was going around in my mind: why is this the case? Why were comparatively speaking, in the data we were looking at, death rates so different between rural and non-rural communities? So this is a question we started to ask ourselves. Next slide, please. And thanks to the European Union, and this is a funding stream within Europe, the Northern Periphery and Arctic Programme, which deals with, I suppose, the rural parts of Western Europe. We were able to actually design a study around this and try and figure out, some of the answers to these questions. And I do want to mention David Heaney, who's pictured here, who passed away, unfortunately, before the study really took off. But he instigated this large multi-country study. And David was an Irishman by birth, but he really had settled. His heart was very much in the West Highlands of Scotland, and he was living in Ullapool when he passed away, unfortunately. And this work is very much dedicated to him. And many of you will have known David through various rural initiatives over the years. Next slide, please. So one of the key questions we wanted to ask is, what is the data telling us about incidence and of COVID, and also of death from COVID in rural versus non-rural regions? The NPA region defines the most rural regions. So when we compare those, we saw that and this is across, here's the different countries you see listed here. Scotland's included, Norway, Finland, Ireland, Northern Ireland, Sweden in this particular data set. And we can see that the death rates from COVID were half what they were in non-rural areas. Next slide, please. So that's a really significant statistic. And then when you try and drill down and why is this? And obviously there's a series of explicit reasons, things around low population density, accessibility, low economic diversity, but it really doesn't explain it, or it certainly didn't explain the really significant difference to us. And in the qualitative research we did around this, it became very apparent that it is down to things like social cohesiveness, flexibility, diversity, the ability to adapt, which we're all so used to doing as we wear many different hats in our different rural communities. And in many ways, some of it is summarizing this quote: in hospitals, diseases stay and people come and go, but in the community, people stay and diseases come and go. So we look at these challenges in a very different way. Next slide, please. And I suppose in many ways, when this answer came to us, it wasn't really surprising, because this is a campaign that I co-founded some years ago, where we were very much on our knees in terms of trying to preserve rural healthcare units within rural communities in Ireland. Again, that taught me a lot of things, but fundamentally it taught me the power of ground up initiatives. And that's why I think it becomes really apparent when you're involved in rural that yes, the answers are winning communities themselves. And it's really important that you involve the power of communities. And if you do, when you're seeking answer to questions, then you're far more likely to have a positive outcome. If stuff is imposed on communities, they become disempowered and passive recipients of a service as opposed to active agents in their own lives. Next slide, please. So, in many ways, it was a revolution for us at the time. And some of the politicians may or may not be happy to hear this, and many of them, I'm sure, have come up through rural communities. So we had to put forward candidates for the general election, which occurred around at that time, because we very much realised that this had to come from the communities themselves. Next slide, please. And really, this involved large, community-based meetings all across the west of Ireland, and it was amazing, really, to harness the power, the people power that was evident at the time. Next slide, please. And around that time, actually, in that winter, we had a particularly wet winter, and this is a picture from the main road in our own village where our practice is, and our medical practice got flooded at the same time. And we were in a real crisis situation. The whole village essentially was flooded. And of course, the solution didn't come from anybody other than ourselves. This is the moment just before one of the local farmers drove the front of his tractor through the seawall to let all the water out and drain away from the streets and indeed the medical centre at the time. So, but it really brought home to me the importance of really supporting solutions that come from communities, because they know exactly what's going on and how to find the solutions. Next slide, please. So what it meant for us is putting up a local candidate in our area. We were very lucky that he was elected what we call a TD, which would be the equivalent of an MSP. And we actually were involved in the balance of power at the end of the election. So he ended being elected the chairman of the Joint Houses Health Committee at the time, and through that we were able to really reorientate the health policy, the national health policy, through the development of a thing called Sláinte Care, which is the accepted all-party healthcare policy currently in Ireland, which reorientates healthcare to primary care and community-based care. Next slide, please. So it really does make you think about this whole idea of resilience. How do you develop resilience within a community? How do you harness the power of communities? Because when you talk about resilience, it was this guy Anton Antonovsky, an American sociologist, who first defined it back in the 70s with his seminal book Health, Stress and Coping. And he really talks about the importance of life being comprehensible, manageable, and meaningful. And that's what we have to try and create within our communities in order to increase resilience. Next slide, please. Because if you do that, it really takes you away from this sort of deficit-based response that a lot of us would have been familiar with, where outside agencies come in, they define a problem, a need, or a deficiency. They design a service to fill the gap or fix that problem. But in the process, of course, as mentioned, the communities are disempowered. They're not part of the solution. They haven't co-created the service, and people become passive recipients of often what is not an effective service, rather than active agents in their own lives and own solutions. Next slide. So I'd be very much urging an asset-based approach, first defined by Antonovsky, which makes visible values and values the skills, knowledge, connections, and potential in a community. It promotes capacity, connectedness, and social capital, which we've already heard about some great examples of. And it's very much concerned with identifying what are the protective and health promoting and health well-being promoting factors in a community, and how do we enhance those, and how do we enhance the self-esteem and coping abilities of not only individuals but also communities. Next slide. So this is a picture of the medical centre here on the right hand side, and I'm lucky enough to sit in the corner office every day, and I hear the sounds of the playground outside, which of course as you do in a rural community, you wear many hats. So I had to chair the playground committee in order to build the playground. But it does strike me that these are the type of resources that we need to find in our communities, because it often strikes me that, you know, people coming together and children running around and adults meeting in this area is probably going to be a lot more effective than any medication I ever prescribe in the medical centre next door. Next slide, please. So I suppose in many ways, to summarize, it is for me about you know, social capital within communities. It's about empowering communities. It's about working with communities. But I think ultimately it's about changing the narrative that we have around rural, because otherwise we create a self-fulfilling prophecy which none of us actually want. Thank you.
Great. Thank you, Dr. Glynn. That is great. The flooding images reminded me of what had been going on in Dumfries and Galloway in the last few weeks. I'm sure Finlay would agree with seeing the tractors in about the water. So thank you very much for that. Okay, I'm going to move on to our last but not least. We have colleagues calling in from the Centre for Rural Medicine in Västerbotten in Sweden. Andreas Lundqvist, I hope that's right, and Annette, see if I can figure this out, Eden Liljegren. Okay, so you're going to discuss innovative research activities in the rural technology and health. And I know you're both online, so I'm just going to pass on right over to you.
Thank you. Thank you for that introduction. Great work with our names. I wouldn't perhaps quite have pronounced it that way, but it works. I think I'll try to share my screen from my side. So please let me know if this works and you can see my screen now. See if you can give me a thumbs up or something if you can see it. It looks good. Okay, let's start. Hello from Sweden, I should say. My name is Andreas Lundqvist, and I'm the head of unit at the Center for Rural Medicine, which is a small research and development unit in Region Västerbotten in the far north of Sweden. We have our main office in a small rural town called Storuman in the inland parts of Västerbotten. And this picture that you see before you is taken from our nearest mountain overlooking the town and the lake with the same name, Storuman. And to put everything in perspective, I saw that Scotland covers almost 79,000 square kilometers with a population over 5 million people. The county of Västerbotten itself covers more than 55,000 square kilometers, but our population is only 275,000 people, and most of which live by the coast. This means that the inland and mountain parts of Västerbotten are very sparsely populated. In some municipalities, there are less than 0.5 persons per square kilometers, meaning that in some EU statistics, they don't exist at all. What is also specific for our area is that the population is quite old, with a large part of the population being over 65, over 30% actually, and many are also over the 80 years of age, 8 to 10% depending on what municipality we're looking at. So we are sparsely populated, our population is old, and we have long distances to almost everything. So these, of course, are all factors that puts pressure on the healthcare and care system, and we have tried to address these issues with research and innovation projects over the years. So we work with research, development, innovation, and education for and in sparsely populated areas. And we do so in the areas of good quality, local and equal healthcare in sparsely populated areas, Sami health, health for our indigenous people in Sweden, recruitment and retention. And for us, it's a matter of credibility to actually be based in a sparsely populated area. There is often an outside perspective when rural or sparsely populated areas are to be involved in research and development. And we have a strong belief that this is not how it should be done. So historically, we've worked quite a lot with how we can move healthcare as close to the population as possible, many times using various sorts of distance spanning technologies and solutions, and also point of care diagnostics. But we've also worked with how we can evaluate and strengthen the healthcare that is conducted physically in our part of the county through the cottage hospital model, a form of extended primary care, and also a very good example of integrated care. And with this slide, I only wanted to show you that we have a very wide global network of collaboration partners. sparsely populated regions is, of course, not a local phenomenon. We have lots to gain from collaborating and learning from each other and together. Many times, sparsely populated areas have more in common with other sparsely populated areas globally than they might have with urban areas in their own country. And what is also a known fact is that systems and solutions that are developed in sparsely populated areas can be easily transferred to urban areas, but the other way around seldom works. And lastly, before handing over to my colleague, I would just like to mention that as of October last year, the Center for Rural Medicine and South Lapland Healthcare District have been selected as a demonstration platform for WHO Europe for primary care in rural areas strengthened by digital tools. We had a big inauguration in Storuman where Dr. Hans Kluge, the regional director for WHO Europe, and the first international delegation from Georgia, led by their Deputy Minister of Health and Social Affairs, Dr. Tamar Gabunia, visited us and learned about the cottage hospital model and the research and development that we do. And we are, of course, very proud of this. This spring, we will have visitors coming from Kazakhstan and Spain as part of the demonstration platform together with WHO Europe. And with that, I give the floor to my colleague, Annette Edin Liljegren, who will tell you more about our research. So Annette, the floor is yours.
Thank you, Andreas. Good evening, everybody. Nice to be with you tonight. And my name is Annette, as you have heard before, and I'm working as a research strategist at the Center for Rural Medicine. And I'm also adjunct lecturer at the Department of Epidemiology in the Department of Epidemiology and Global Health at Umeå University. And I will give you some glimpse of our research, and the research areas are focusing from this circle. You can see these areas that we have researched within, and unfortunately we have not included. We have one COVID research project together with Stockholm and another university, but we haven't included that in this presentation. However, I will present some of our research projects very briefly. And our research are focusing on solutions and methods for good and close care in municipalities and regions, from the individuals to the system. And the first one that I will mention to you, can you take next slide, please, Andreas? It's about a dietitian online. And it's a PhD project about the dietitian online. And the student is a dietitian earlier working in our rural area in the cottage hospital. And the aim is to investigate the effect of internet-based dietetic treatment in Sweden on patient, dietitian, and society. And GMC, Center for Rural Medicine, is also funding a part of this project together with the Industrial Doctoral School for Research and Innovation at Umeå University. Yet another PhD project, next slide please, is to develop a digital model for medicine therapy optimization for patients in primary care, where clinical pharmacists conduct digital medication interviews and medication reviews among elderly people living in our region. Further, we will assess the patient's benefit of this digital intervention in terms of drug-related problems and quality of life, and explore experiences of the digital intervention. And the PhD student is a pharmacist, and I am one of her co-supervisors. Next slide, please. The third one I will mention in this area is meeting with value, expectations and experiences of digital meetings with healthcare from the perspective of people living in rural area. The aim is to gain more knowledge about experiences and expectations of meetings in healthcare provided through digital solutions from different groups of people, for example, elderly people living in nursing homes or ordinary homes in everyday care, and how the meetings can be more effective both in terms of resources and quality. Next slide, please. In the area of recruitment, we have a project among medical students. We have also lack of medical doctors, of course, in our area. as you mentioned earlier. And we have made a study among medical students about attitudes to working as general practitioner in rural area, and it's a long-term study. And from earlier research, it is stated that you should focus on individuals or students that have been born or brought up in rural area if you want to recruit people, because it's higher chance that they will come back and work closer to their homes. And the main question in our study is what is important when selecting medical program or specialist training and workplace. And we started this project 2012 with a questionnaire to medical students in semester 1, 6 and 11 in Umeå and Uppsala. Uppsala is a town in the south of Sweden, and Umeå in the north. And we have followed the students from semester 1 when they were in semester 6 and semester 11. And now 5 to 6 years after they finished their education, we are going to do a follow-up that is planned actually to be done this year. And we would do interviews and ask them why they are working where they are and what was the most important factor. Earlier follow-up among the students have shown that 3 factors were most important when the students should choose workplace and medical program, which were that it should be an interesting specialty, of course, you can say, a possibility to combine work and family life, and access to social network. These factors were important in the follow-up studies. We have, next slide, please. We have also an obligation to do research about Sami health. And the Sami is the indigenous population in Sweden, and we are working to provide good healthcare to the Sami population. We have 2 Sami nurses that have completed a doctoral degree, Laila Derga, with her thesis about to live in 2 worlds, health aspect among reindeer herding Sami. And Lena Kroik with her thesis about Sami and end of life, knowledge and traditions to develop care in the future. And we have further on done some application to study more about health and working environment among the reindeer herding Sami. And next slide, please. And finally, we also have education, as Andreas mentioned a little bit about, but when it comes to research, we are supervising students in their scientific projects and also PhD students. Yes, next slide, please. I think this was the final.
This was the final. Thank you, Annette,
yes.
and thank you for us. I could just briefly mention, as Leith said earlier, that he was looking for collaborations. We always look for collaborations, so please contact us if you find our presentation interesting and you want to know more about the work we do. So thank you.
Thank you.
Thank you to you both. Shall I try pronouncing your name again? Andreas Lundqvist and Annette Liljegren.
Excellent work. Thank you.
Thank you. I'm a member of the Health and Sport Committee, and we are looking right now at rural medicine and rural healthcare issues, and I'm also co-convener of the Mental Health Cross-Party Group. So everything this evening relates directly with what I'm doing anyway in Parliament. So thank you everybody for your presentations, and now we have time to open the floor for questions. I'm going to ask folk to put your hands up if you're in the room, but also you can put your question in the chat function if you don't want to ask it live, or put your hand up and Jane will keep me right about whose hands are going up first so that we take them in a fair and orderly way. And I am basically going to open it up for questions. Yes.
Hiya, I'm Kate and I work for SRUC, and I was just wanting to say for all of the presentations how interesting they were in their different ways and different elements. So I wanted to highlight what Leith said about tailored interventions, because we've been working with farmers, and I'm seeing RSABI there in the corner on the screen, and the importance and the effectiveness of tailored interventions for a community, and the communities that we've been working with, their farmers. And the other project that I'm involved with as well with SRUC is the Farm Strong Scotland project that's emerging, and that is led by farmers. So it's a community-led intervention. And both of these things are talking about solutions, and the results from our CS, it's a Chief Scientist's Office funded project about farmer mental health, and the results were, we've got a lot of data, but interventions do work. It might be as simple as speaking to somebody like through RSABI, it's a charity in Scotland for farmers, and so somebody that understands the challenges that you face. So it's just simply having somebody to talk to. And that can be somebody that's, you know, anonymous and at the end of a telephone, or else it could be practical support, or it could be mental health support like CBT. And that asset-based approach is a really positive response because farmers are very resilient people, and it's good to support them to be more resilient rather than just talk about the difficulties that they face all of the time. And it's not to take away from the difficulties that they face, but it's to try and be solution focused. So my question really, we also have done some work with the mental health and well-being of farm vets, veterinary surgeons. So I was really opening to any of the speakers, if they've got a specific interest in farmers or farm vets, it would be really great to hear about it.
Yes, Kira is going to answer that one.
Just on that, it might be good actually for us to link up after this, because Jim and I behind the scenes are currently looking into the mental health of vets. I don't think I'm allowed to go into too much detail, but there is something currently starting to be done about that. Sorry to be a bit cryptic.
Good, that's interesting. Wondering if, oh yes, yeah, go ahead.
Hi, yes, I'm really interested in that because obviously one of the big things is food and how we've kind of denigrated the farmer to, you know, and really how can we possibly be a healthy, happy nation again without great quality food, which is abundant in our land. So yeah, I think there's a rebranding has to go on, and obviously all the other things that we offer. I think, you know, farm visits and people really getting back in connection with the local farmers is critical to move forward. So yeah, I would love to chat to you about that.
And valuing these people and the contribution they make.
Yeah, absolutely.
Thank you. I see Finlay Carson, MSP, has a question, and then Leith wants to come in.
Thank you. Where do we start? I think connected with every contribution we've heard tonight, really good. What I would like to ask our friends in Ireland and Sweden is, was there a conscious decision by government to support your activities? I sometimes think that in Scotland we see that it's disproportionately difficult to deliver services, and there's not a realisation that that's the case. So if we want to see people live in rural areas, the government have to make an active decision to make that happen. I think we missed a huge opportunity through MPF4, which looks at 20-minute communities within urban areas to ensure within 20 minutes you have the critical services that are required to make a community sustainable. And we've really missed that out in rural communities, where we need to decide whether every village needs a doctor or every village needs access to mental health, because you've got to make a far bigger effort, because if you're in an urban area, you can walk down the street and walk past the mental health support office, if you like. In a rural area, you've got a conscious decision to get a bus, and then you've got to walk past the place 2 or 3 times before you get the courage to go in. And during that time, you find an awful lot of excuses not to do it. So back to my original question before I ramble on. We don't have, or in my opinion, adequate funding for rural areas that address rurality. We struggle to get GPs into rural areas, and I don't think there is a conscious effort to ask GPs what they actually need to come. We offer them £25,000 golden handshakes, and we put them in hotels up for the night and show them how lovely the area is, but it just doesn't work. So what intervention was there from government funding bodies to ensure that there was active movements to ensure people could continue to live in rural areas and address these GP situations?
Thanks, Finlay. I think we'll we'll see if we go online for that, unless Leith wants to pick up, was it a previous point? Yeah, okay.
So I know Liam and Andreas have unfortunately had to leave. I don't know if Annette is still there from Sweden to comment on that. If not, they've said to email them any questions and they'll come back. So I've noted that one.
If excuse me, can I make a comment on that pertinent, if I may?
Fiona Morrison.
Fiona, yes, of course you can, Fiona.
It is not my place to speak for Professor Liam Glynn, but just because I've worked with him quite a lot of times before this meeting, and I know that, and I think maybe he showed the slide, no doctor, no village, and then he talked about how his colleague ran in the political campaign, and they won. He spoke about that, and then how ultimately they meant that colleague was on the health committee in Ireland. Now, what he didn't say was, and this maybe answers the question in the room, so if I can just paraphrase what Liam has said many times, is that this now means that there is a GP, a rural GP on every health area in Ireland. So we might say in every health board or every district or whatever. So every area in Ireland has a rural GP. In fact, Liam's colleague was Robert Scully, who set up ScotGem in Scotland, as you might know, which is the rural medicine programme. So those two gentlemen, and I can't speak any more for them, that would be unfair, but I know that they have definitely seen an increase in more rural action, if you like, as opposed to centralised action. Liam did some evidence-based research where he demonstrated that rather than having patients travel all the way to a city, let's say for an ingrowing toenail, which perhaps needed, endless travel by the patient, perhaps needed to be taken there to some kind of city hospital for treatment, that he could treat that more cost effectively in his own practice. So let him tell you more of that when he's available, but I just wanted to illustrate how what he told you tonight did follow through and the very positive impact it has had in making sure that there is more provision at a very local level as opposed to a centralised level of sending everybody off to cities and so on, and the cost implications of that, as well as the impact on individual lives.
Thank you, Fiona, for that. I was going to mention ScotGem actually because I was on the health committee when we took the legislation through. So it's interesting to hear Dr. Scully's name about it. So that is something that we're taking action for. And, I'm a rural MSP as well and a nurse. So it's interesting to hear how do we attack or work on all these rural issues. And Leith, you wanted to come back on a previous comment.
Yeah, I can actually kind of comment on both. So a little bit starting with the most recent one about rural funding medical care. So I was funded out of a provincial ministry that focuses on rural affairs and agriculture. And I do think, and I'm also based on the Ontario Agriculture College. So that does allow for us to have a really specific and special relationship that accesses research dollars. In terms of access to funding for physicians for rural spaces, Ontario, I mean, there's lots of things you can say that are wrong with Ontario, but one thing that they are trying to do is they've implemented family health teams so that based across the province, there's these FHTs that promote or provide primary health care, but also access to specialized medical care. Unfortunately, my argument against that would be a lot of that rests on the individual themselves. So if you happen to have somebody within that FHT that is aggressive, that is motivated, that is out there, they probably have better service provision, as opposed to if by chance it's someone that maybe might be closer, not to generalize, but could be closer to retirement, could be have balancing whatever's going on at home. So it does vary considerably. We do struggle with the provision of care equitably, no matter what. And I think it is a really interesting argument that if you do, I'm born and raised in small town, like a general store small town, and to assume that I would have access to a physician within my little small town is sort of laughable. And I think that's just kind of the assumption. I'm, like I mentioned, born and raised in Canada. I left the province of Ontario for 7 years. My mom works in the medical field. And when we came back to Ontario, we never got a physician in our small town. I pulled every single string I had. I pulled everything that I knew, and we still have to travel. So it's still a real big problem, and that's with somebody that can access the system. I think if you want to put another layer of complexity on that, make that a new immigrant, make that someone who doesn't speak English as a first language, make that someone who is a female who needs specialized female driven care, and it just layers on top of it. So it gets really, really, really difficult. The actual comment, though, was about ag data. So in the first section of the survey, we had 12 questions that were really, really specific, so we could slice. One was sectoral employment. So we can slice and pull by agricultural productivity or agricultural self-identity. We also did, so you can pull that subsector super fast because whatever, the system does that really easily. We also sliced, or we can do it anyway if you want, gender, age, sectoral employment, distance from a primary care facility, and so forth. We did ask, how long have you resided in the area? Because I think much like many places, we've seen a mass in-migration to rural spaces, largely exacerbated by COVID. So if they indicated they had been there for less than 3 years, did they have trouble accessing healthcare, specifically daycare provision for children, specifically primary GP provision, and then home actually purchasing or renting a housing. So we're able to do that as well. So if there is an ask that you're interested in, then it's manageable. Thank you.
Thank you. Other questions? I know that the slides will be available and will be put on the CPG for Rural Policies website. Jane's nodding.
Yep.
So, because I know there's a lot of data that's been presented, and that I find it really, really helpful and useful. And then in the middle of the night, I'll wake up and go, oh, I wish I'd asked that question. But wondering if anybody else has any questions or comments. Yes.
Hi, this is more to highlight some research that we did at Ipsos Scotland for Highlands and Islands Enterprise. We did a large study with 5,000 people in the region called My Life in Highlands and Islands, and we asked people if they can access various health services within their local area or within a 20-minute journey of their local area. I wasn't planning to speak tonight, so I don't have any statistics on me, but it won't be surprising to know that access was way more difficult for people in remote rural areas. And there's a lot of other things in the survey, so I would be happy to share that with anybody who's interested in seeing the data on that.
Good. Lots of experts in the room tonight. Leith, yes, you want to come back? Thanks.
Sorry, I apologize. This just came to me, just your example of lying about a night. The provincial government just made it possible for pharmacists to prescribe, and not for everything, for things that obviously they should have been able to do a long, long time ago. But I think they were getting tremendous pushback from the physician association, and honestly, it's because of billing. So finally, they've been able to get around that because it is easier to access a pharmacist. So I think there's like 10 to 15, like maybe you remember the numbers, but there's about 10 or 15 specific medical conditions that now pharmacists can prescribe for. And so that's a relatively simple way, I think at least, to kind of skirt some of the issues around GP access.
Thanks. I do have a question as well, but I'm going to have Ailsa come in first.
Yeah, it's just really a question to ask about social prescribing and how effective has that been, or how could that be further extended, particularly in rural areas where, you know, there is very strong networks of community-led organisations and a whole range of potential benefits that could be more accessible than perhaps having to go up the road to Glasgow as we do from Campbelltown. So
I can come in.
Kira can take that. And I know that Health Committee have a report called Rural Prescribing is an Investment, Not a Cost. And because we did an inquiry about rural prescribing, because it's something I really, really think is really worthwhile.
Yeah, so social prescribing is something that we have done previous research on. I can send you the link to that. There's a few areas, sections in it that do focus on rural, but in terms of that social prescribing link, I don't know if you've heard of the Community Link Worker project. So that is, we at Change Mental Health, we provide that in the Highlands. So yeah, I'll be honest, some of them are in Inverness, but there are a lot in some of those really small rural GP practices. And I know that some of them, we have a few that are in quite remote areas that are, say, working out of like local community churches and wee halls and stuff. And I know that's something that in the future, currently, at least in the Highlands, it's different in each local authority area and depends on the third sector provider. So for example, we're doing it with UHI right now. They are looking at in the future to be able to that to be self-referrals, and also so people don't actually have to go through a GP. They can actually just go and see a community link worker. And we also have in Stranraer, we have a community networker, and basically Georgia is based at the Millennium Centre, and she essentially does very similar jobs to a community link worker. It's just it doesn't have to go through your GP. And again, that's something that we're looking into, seeing how we can get that into different rural areas as well.
Okay, is that okay? Seeking any other questions, any info? Yes, go ahead, Finlay.
Just some comments. I think the service has been delivered specifically for what that community's needs are is really important. And in Wigtonshire, as you'll know, Emma, we had a community engagement programme that tried to identify what the critical services were required for every community. And the question was asked, is it reasonable to expect these services to be delivered here or somewhere else? And in Dumfries and Gala, we have a new hospital. It's often described as the Death Star because it sucks resources in from rural areas, and people are having to do journeys which are not reasonable. So it's not reasonable to expect a family to travel 140 miles to see their loved ones get palliative care. It's not reasonable for a pregnant woman to have to travel 2 hours to get to the maternity hospital, but it might be reasonable to go for cancer care. I just feel sometimes the place-based information is so critical to decide what these services are, and too often we have decisions taken at national level which are not rural proofed. I think it was on one of your slides about rural proofing, but we have drug programs which are based on urban drug issues. It's not reasonable to expect to have a safe consumption room in a small village of 400 people. So what's the other alternative? Well, there isn't at the moment, and we have some of the worst drug issues in rural Dumfries and Galloway than urban Dundee or Glasgow or Edinburgh. The higher percentage of drug deaths in Dumfries and Galloway than anywhere else in the country last year, but not specifically targeted support for those people. And we need to look at what the communities need rather than settle down policies.
Can I piggyback on the back of that? Because I think, so we do absolutely know that, palliative care, I know people like to say, oh yeah, you can die at home and with dignity and everything, but there are family members that maybe can't do that. And so palliative beds might need to be in a special place or a special unit. And I totally support that. And I'm just thinking about the things that, like in Glasgow, there's an outreach bus for diabetes. So get your finger stick blood glucose, get your hemoglobin A1C, get what you need for that. But then there's also outreach CT scans, outreach MRI. So, and then also there is research going on right now about benzodiazepine reversal agents, because that's what we're seeing in rural areas. People buying their blue benzos from Diaziman on Facebook. So, and you don't know what that is, that blue benzo is. It's 1,000 milligrams of diazepam in one tablet. So there's stuff that's going on right now, and I think sometimes it's not happening fast enough. But I'm wondering if you have outreach bus type stuff to go to rural places to help maybe tackle some of these rural issues.
Okay, so yeah, I was just at it's called the Rural Ontario Municipal Association Conference. It was held last Sunday, Monday, and Tuesday. And I was there because I have a PhD student who is federally funded to look at the role of health units in Northern Ontario and some of the unique challenges. So a two-part answer here is yes, we do have that. There's a pilot study that is being run. I can't remember. It's rural Eastern Ontario, somewhere closer to Ottawa, but it is a rural mental health bus, for lack of a better word. And what it allows is a mobile station that travels much like you're describing. And within it, they guarantee high-speed internet access so that if they need access to a psychiatrist, they're able to make sure that that's possible. And it is just a pilot study, but it is a really interesting, really super fascinating possibility for rural individuals who otherwise, for whatever reasons it might be, cannot access care. The other thing about this that I'm working on with one of the family health teams is developing an intake form so that perhaps we can identify maybe virtual care is perfect for this individual. And maybe that is appropriate and useful, as opposed to maybe this individual, they require face-to-face. More often than not to pick on one specific gender, but if you're a mom at home with your kids, you really put yourself really last. And the reality is you think you can do it all, but you can't. So as much as you think you can do at-home virtual care while your kids are screaming in the background, it's not working. So sometimes you do need access to care that is face-to-face, and more often than not, you need someone to tell you that you need that. So there's a couple of different pilot studies that are being run to see how they can figure that out and what is the best solution. But I do agree with what was said. The biggest, I think, in my opinion, not solution, but partial solution to all of these issues is ensuring that we are asking local residents what's going on, and that we have an opportunity for those local residents to provide that information without asking one rural communities are great, let's not get it wrong, but they get really cranky if they don't get asked. And just by saying you asked your neighboring rural community and not you guys, you're dead in the water. So you do have to ensure that you're providing adequate and appropriate opportunity for engagement. Not that I'm here to speak about this, but we have proposed a national biannual longitudinal, essentially, census of small rural places that the University of Guelph has formally recognized as a fundraising initiative. And the reason it's biannual and not every 4 years like StatsCan is because the scale of change in rural is so significant. And if one new physician comes in, that is like a massive change for a small community. So we are it's going to be a huge funding initiative, over $10 million. But if you can access that sort of data, if you're, Joe Public, the local business owner, or Jane Public, who is a senior trying to access care, we want it to be publicly available data that is almost up to date, because it's every 2 years. StatsCan is fantastic, I love it, but it's every 4 and it doesn't offer the granularity. So it takes funding from the government. Without it, we can't do this. So and it can't be provincial or regional. This has to be a federal initiative, and I would say the same for Scotland as well.
Thank you. Thank you. I am conscious of time, so I've got 3 quick questions for the room, basically, a wee straw poll. Who's heard of pharmacy first? Put your hands up. Okay. I'm glad you have, Finlay. That's right. That means go to your pharmacist first, because they can prescribe. And then the other one is Scott Gem.
Sorry, pharmacists can prescribe?
Yes.
Without your medical records?
Yes.
Yes.
Which they can't do in NHS Highland, which I've been trying to get for years.
Okay.
They can in Galloway now.
Okay.
You must be more advanced down south than we are up north. Maybe it's the Death Star that brought you that.
Okay. Okay, so my next quick question is, who's heard of Scott Gem before it was mentioned tonight? Hands up in the online room as well. Nobody heard of Scott Gem. That's our graduate entry to medical school. Anybody that's got a primary degree in healthcare can be 4-year fast track to be a general practitioner with a rural focus. And my third one is social prescribing. Is that something that everybody knows about? Hands up. Okay, more folk. That's interesting. Okay. Okay, that's me just being nosy. Thank you. Okay.
We've got some hands up online. I don't know whether they're hands up with
Okay,
questions or hands
so
up with.
just check with the online folks, are hands up for questions or hands up because I asked the straw poll? Okay, great. Okay, shall I close it there and tell you about the webinar that's tomorrow between 3 and 4:30 for anybody that wants to continue with this conversation, that Jane has put in the chat function, but also just to make sure that you are aware that there is a webinar to continue this, because it is really important that we focus on rural issues and rural healthcare and rural mental health and everything. So it's something we're very focused on the Health Committee, and the convener of the Health Committee is a North East Aberdonian lass, so she kens what it's like to be in a rural patch as well. So anything else I missed? Any other business?
No, that's all about
in addition.
tomorrow. So
Okay, so that's all about the webinar. Okay, and we know the slides will be available.
Yep.
And the next potential dates for the CPG will be Tuesday the 7th of March and then Tuesday the 6th of June. And I might have to chair half of them, one of those meetings for Edward, because he did it for me this evening, and it will be a joy to do that.
I told you that chairing half a meeting is not enough. We'll sort it out.
So
in
you
the
want
bar
half a
later.
pint of something, half a pint of water in the bar. Okay, and so Tuesday 7th of March and then Tuesday 6th of June, and we'll try and do hybrid again. I hope hybrid worked out okay.
and a
Yeah.
big thanks to everyone who's helped with the tech,
Yeah.
whether it's SRUC or Ashley as well, and to
So
get it running.
brilliant.
Yeah.
Okay, so I'm going to ask for a round of applause for all the speakers tonight, because everybody's given up their time. So thank you very much. And then with that, let you get out of here and go on home.
Thanks, Ellen.
Thank you.